So this was the very first implant of the Assert-IQ EL6. So this patient still has it and has been using it, and we actually did a redo ablation on this patient a couple of months ago for a recurrent persistent atrial tachycardia that was facilitated through the implantable cardiac monitor. So what exactly is the value of dynamic long-term monitoring for chronic arrhythmia management, right? I think we moved the stage from thinking about acute, intermittent, short-term monitoring to more of a long-term dynamic monitoring, because what we're dealing with now are chronic diseases, right? I think the transition from thinking more about a point of care to more of a longer-term chronic care, I think becomes very important when we are dealing with chronic diseases like atrial fibrillation. And that's exactly what we're actually going to talk about. So we know that atrial fibrillation is a very common condition, it's a bane of our existence. It's one of the most common diseases or cardiovascular conditions that you meet in emergency rooms, in patients, you name it, right? There is atrial fibrillation everywhere, to a point where I would call this an existential cardiovascular pandemic that is actually global in its scale. So long-term strategies for atrial fibrillation really become important, whether it is prevention of acute stroke, heart failure admissions, or long-term prevention of dementia, so that your patients that actually have atrial fibrillation are not really going down the spiral in many other ways. And you also have to understand the costs of healthcare management in these patients that really becomes burdensome in so many different ways. And how do you really sort of embrace the evolution of a paroxysmal atrial fibrillation more into a chronic disease that is driven by many cardiovascular risk factors, right? So when you really look at coronary artery disease, it is sort of the electrical equivalent of that is atrial fibrillation with the same underlying cardiovascular risk profile that includes your age, gender, your obesity, hypertension, diabetes, you name it, right? All of these are traditional risk factors that are shared by both. And how do you really use dynamic monitoring as part of what you want to do? So this just lays down the impact of atrial fibrillation on healthcare in itself, right? I mean, in addition to the strokes, heart failures, dementia, the reduction in quality of life and death, there are anywhere from 5 to 6 million Americans at this point in time. The global estimate seems to be about 60 million people across the globe in 2019 that suffer from atrial fibrillation that really need help. So when you look at disease per se, as electrophysiologists, as physiologists, as anatomists or pathologists, we're more focused on finding interventions that have impact on outcomes, right? So there are molecular therapies like antiarrhythmic drugs. There is work that's being done in gene therapy, nanotherapy, cell changes. You have tissue level therapy, which is basically ablation surgery. And then you have organ level. Again, you really look at the surgical procedures and ablation procedures. You talk about energy. The new kid on the block, pulse field ablation, has really come a big way to really understand how we can really move the needle in so many different ways. And then you have sort of autonomic nervous system modulation, whether it is local or regional or central. And then you have more of a cerebral impact on more central interventions like yoga, acupuncture, stress reduction, deep brain stimulation. These are all areas that we continue to explore, but what we really don't want to understand more is how could we leverage the existing diagnostic tools that we have to really shift the care paradigm and really improve outcomes. And that's exactly, I think, where an implantable care cardiac monitor really fits in. So long-term diseases actually require longer-term care, and we have established that with absolutely no questions, right? If you really think about hypertension, you need blood pressure monitoring. You need, even though there are no current devices that gives you longer-term continuous blood pressure monitoring, that's a goal that we want to get to. Diabetes nowadays is continuously being monitored. In fact, Abbott makes one of the most popular glucose monitoring devices that has really become sort of a de facto for any patient that has diabetes. Obstructive sleep apnea requires continuous apnea-hypopnea index monitoring, and the current generation CPAP, BiPAP devices are actually capable of giving you that information. Chronic respiratory diseases, oftentimes pulmonologists love to have spirometry numbers on a regular basis so that they can tweak the medications and interventions that are relevant to that. So it is imperative that the continuous monitoring is superior to intermittent monitoring on many levels. If we really believe that conceptually, because it's already in practice, we should believe that atrial fibrillation, being a chronic disease, really requires a chronic monitoring and a long-term monitoring. So there are different types of monitorings that are available. I mean, you have this external smart digital watches and the mobile EKG techniques or the EKG vests and things like that. So you have the, obviously, ICMs have been around for a while. You have M-cards, you have event recorders, you have holders, EKGs, and all of that. So where exactly these tools really fit in? Is it in the initial diagnosis, or is it for antiarrhythmic drug management? Is it post-ablation, or is it related to the decisions regarding antiarrhythmic drugs and oral anticoagulation use? Of course, all of the above is the answer. And so how long should you monitor them? How good is the quality of the data? And how do you really deal with false positive? And then the patient comfort is really a big issue here. So a lot of times when you really put these external monitors on people for intermittent monitoring, this is not an easy situation because it's expensive, it's irritable, those patches come off, the data is not really that great. And then how do you really tackle the patients who have asymptomatic atrial fibrillation? There is anywhere from 15 to 20% of human population that have asymptomatic AFib that has some real meaningful serious implications in terms of stroke or heart failure and other things. And then what is the overall cost of this intermittent monitoring versus continuous dynamic monitoring using an implantable cardiac monitor? So I think these are issues that need to be really grappled with so that we can make appropriate decisions in really providing chronic long-term monitoring capabilities for our patients. So this is where I think the next generation ICMs really come into play, right? So for a while, the older generation of the devices has issues with the battery life, and I'm glad to see that the team here actually has gone out and really worked hard to really come up with a new generation of devices that have extended battery life and also extended qualities and features that are actually become relevant, right? So if you think about it, the advanced longevity, the enhanced EGM clarity, and enhanced detection capability, and advanced diagnostics. I think PVC burden once upon a time was really not anything everybody thought about. Now, knowing what the patient's PVC burden is a very important facet to managing patients' cardiac conditions. And having an additional feature like the body position and posture, right? So when you really look at the indications for implantable cardiac monitors, syncope, cardiac dysautonomias, I think is a very important subgroup of patients where you want to get the data, right? So this particular feature really excites me a lot because the body position and posture, correlating patients' heart rates, heart rate variabilities, and the dips in their heart rates and associated symptoms with body posture, getting that piece of data on a dashboard in front of you, I think really makes a huge difference in order to really assess the impact on patients' quality of life, their symptoms, and also the impact of therapy on these patients to really see what you're doing for your patients is actually helping or not. This actually goes back to even tell you the role of cardioneural ablations, the role of hybrid IST ablation, right? So monitoring response to therapy is an important feature. So we're transitioning from using the implantable cardiac monitors from being solely a diagnostic unit for disease identification to more of a longer-term disease management strategy, right? That's kind of the natural evolution that I see in this case, and that's where some of these new features really enhance the capabilities of this device that did not exist before. So elevated heart rate with and without activity, right? That's a very important facet to monitoring a lot of patients with inappropriate sinus tachycardia. This is a great tool that you could use to really monitor therapy. Remote programmability. This is something that was never thought to be feasible at all, but now you can actually do that remotely with a click of a button, and the patient don't really need to come into the facilities to really get this done. So this particular idea comes from this study that we did, and it was a late breaker last year. It's called the Monitor AF. So the question that we asked is, if continuous dynamic implantable cardiac monitor driven therapy of atrial fibrillation is superior to conventional intermittent monitoring? This is a very simple question, right? So what percentage of people out here typically do use intermittent monitoring for your AFib therapy? Show of hands. How many of you actually use ICMs on a routine basis for management of atrial fibrillation? Maybe one or two, right? So that just goes to tell you that the current practice hasn't really embraced ICMs in your workflow. And we're going to learn a thing or two here based on what we found in this, right? So it's a multi-institutional prospective registry. We took all the patients that actually had implantable cardiac monitors as part of their AFib management, and we compared them to patients who didn't have ICMs, who were essentially managed with external intermittent monitoring. And then we looked at those patients' outcomes. So the clinical outcomes that we really wanted to look at is the access to care, right? So it's actually fascinating to see that the mere presence of an implantable cardiac monitor in a patient actually changes the care pathway, the care dynamic in an amazing way, because they have a ready-made access to an electrophysiologist who's actually going to expedite everything that these patients needed in a snap, right? So time to initiation and change of antiarrhythmic drugs and oral anticoagulation. I mean, that's the biggest problem that we have in the management of atrial fibrillation. So prescription compliance, access to ablation, time to ablation. Why are these important, right? At a micro level, at a tissue level, at an organ level, we are trying to push the needle to come up with innovative therapies, innovative catheters, energy sources, lesion sets, the whole 9 yards, all that, while the fundamental issue of access to care and patient care pathways actually have never been improved upon. This is where the mere introduction of an implantable cardiac monitor changes the care dynamic and the care paradigm to a significant degree, helping clinicians to move the needle in a big way. That's exactly what you're seeing here. So the presence of an implantable cardiac monitor results in decreased strokes, TIAs, AFib-related hospitalizations, and heart failure-related hospitalizations and bleeding complications. How do you really explain this, right? The way you explain this is when somebody has an implantable cardiac monitor, they are most likely to be closely followed by their cardiologist or electrophysiologist. That results in immediate change in care patterns, right? That means a patient is more likely to get a timely anticoagulation initiated. That means there is a less risk of us missing those strokes and TIAs and systemic thromboembolic events. The initiation of atrial fibrillation leads to immediate change in AV nodal blockers, initiation of antiarrhythmic drugs, a better opportunity to really send them to catheter ablation much earlier than waiting for months and months together for them to be caught. And the time to ablation also significantly increases. So what it does is it results in a cumulative reduction in cardiovascular complications. That means if somebody gets a successful ablation and they get taken off of oral anticoagulation, they're asymptomatic. If there was no monitor, there was a high likelihood that this asymptomatic patient would have had a stroke from a recurrent episode of atrial fibrillation lasting for many hours. But it's the same ICM patient, it really helps you to immediately intervene and start that patient on oral anticoagulation so that that stroke was mitigated in this case. The same thing applies to heart failure. So uncontrolled atrial fibrillation that remains asymptomatic, you have a much better opportunity for patients to be treated more aggressively and more immediately, thereby you could actually have some real-time reduction in cardiovascular complications. So it is fair to summarize that a dynamic implantable cardiac monitor driven AFib management helps us to improve access to EP care and ablation. It helps us to improve the oral anticoagulation compliance, because the moment your remote technician sees a patient having an episode of atrial fibrillation, the immediate thing that happens is they're going to open up the electronic medical record to see if they're on oral anticoagulation or not. When they are not on oral anticoagulation, that individual pings your nurse, your aligned nurse, who in turn is going to call the patient and make sure that patient gets put back on oral anticoagulation. Seems to be very simple, but it's a simple tweak in workflow that can bring about all these changes. So time to catheter ablation, redo ablations, freedom from atrial fibrillation, the whole 9 yards, all of that. So to really summarize, what all I can say is using implantable cardiac monitors for management of chronic diseases, it's feasible, it is extremely effective, and it's a very simple step in the process that can really result in some serious changes in outcomes in a very positive way. So that being said, there is, I think, an opportunity for using something like a 6-year EL6 really could be a phenomenal opportunity to be used in patients with atrial fibrillation so that you can actually follow these patients in the longer term and then be able to appropriately intervene for all the things that these patients needed. So better monitoring leads to better outcomes and better decisions. Rather than rely on nuance and gumption, I would say I much rather treat my patients based on clear-cut dynamic data rather than making assumptions about whether somebody is an AFib or not. So to conclude, ICM patients experience much lower rates of complications and better disease management, as we have seen it with diabetes and all the other type of chronic diseases. So that's it, and we'll be ready for questions.
Thank you very much for the presentation. That was wonderful. I was curious, how does ICM currently compare to what's available in digital technologies?
Actually, there's no comparison because the currently available digital technologies are still intermittent in nature, right? Even your so-called Apple Watch or other things that you do, the maximum you can only get an electrogram when you use it, right? They're still point of care units only. And they still have a lot of problem with false positives and false negatives. So the data that you get from these digital technologies is still not there yet, right? So I would not even compare them because they're just not there yet, right? So whether it is the duration for which you can monitor them, whether it's the quality of the electrograms that you or the EKG that you could get, and the definitiveness with which you can actually arrive at information is significantly better, several tens of folds better than any of the existing digital technologies we have.
I have a question. So ICMs have many indications, and we touched on how the 6-year longevity can benefit atrial fibrillation. What other chronic diseases do you think could also be helped from long-term monitoring?
I think it's a great question, Megan. As I said, cardiac dysautonomia is not an acute disease, right? It's a chronic condition, and it needs chronic management strategies. So of the spectrum of cardiac dysautonomias that you look at, inappropriate sinus tachycardia, right? You put these patients on beta blockers, calcium channel blockers, ivermectin, you offer them sinus node modification or hybrid ablations. How do you really monitor these patients? You want to really see the nocturnal diurnal variations in heart rate. You want to look at the heart rate variability. You want to look at their exercise tolerance and what is their activity level, right? So these are clear indications where you can actually use these devices to really use them for disease management, or following up the impact of an intervention and manage them in the long term. So let's take the example of vasovagal syncope, right? Or you have interventions in terms of using mitodrain, lower extremity compression stockings, exercise training, cardioneural ablation. This is a great example. Somebody that actually had repeated episodes of asystole, severe bradycardia, all of a sudden, after the cardioneural ablation, you see that their heart rates beautifully go up, number of episodes of bradycardia or asystole goes down, right? So you can use the same thing with parts. Another important condition that oftentimes we miss out, I think there is a tremendous opportunity, is myocarditis, right? Myocardial inflammation of whatever etiology is the single most unrecognized, less appreciated pathology that has tremendous implications to sudden cardiac death, downstream development of full-blown non-ischemic cardiomyopathy with heart failure, and so many of these things. The point of entry for many of these patients is it could be a high burden of PVCs, non-sustained VT, MINOCA, that means myocardial infarction with no obstruction of the coronaries, and dual chamber arrhythmias, right? So if you really want to manage these patients appropriately and have a handle on things, an implantable monitor actually is a fantastic opportunity to manage these patients in the long term. So I actually use ICMs for PVC ablation, PVC management in so many different ways.
Yeah. there's a lot of patients that fall under that umbrella. So that's cool. Do we have any more questions from the audience? Oh, perfect.
Thanks a lot for this nice presentation. I have a question concerning scalability of the technology. How do you see that in the near future?
A great question, right? So how could you take a concept like this that was implemented in one unit in our system into a broader scale? I think quite a few electrophysiologists across the world actually realize the inherent value of the implantable cardiac monitors. I think you see significant number of them slowly moving towards using ICMs in chronic arrhythmia disease management, right? I think it's really scalable, and if you think about it, there's only one element in all of this, right? It's implantation of the ICM, and it's the ability of that patient's insurance actually approving that, right? So in most of these, I would say a lot of these patients automatically had 1, 2, 3, 4 external monitors already, and so it's very easy to make a case to the insurance company to actually have an ICM approved, right? And even after a denial, a single phone call to the peer-to-peer review, it's not really that hard to convince them because they see the obvious value, right? Multiply 5 external monitors times $2,000, right? In a year's worth of following post-ablation, $10,000 for post-ablation following versus $5,000 for an implantable cardiac monitor, where your ability to make appropriate therapeutic decisions is significantly superior, right? That's an easy case to make.
Thank you, Dr. Lakkireddy. Are there any other questions from the audience? Well, I would just like to say cheers to 1 year of helping patients with Assert-IQ. Thank you so much for tuning into our in-booth session today, and we hope you all have a lovely lunch.
Thank you very much.
Thank you.